All right, guys, take a seat. Let's start. All right. No. Cool. Hi, guys. How's everyone doing? Not good? Good? No? Nothing? All right. Cool. So today I'm going to be presenting on hematology. I'm sorry the slides aren't up. I was making them during Roberta's presentation. So apologies for any typos, etc. I really am not a fan of hematology, if I'm honest. There's really just one reason that I'm here. I had to organize the Year 3B lecturers, so like Roberta, etc., to present these. And there are exactly 13 topics. And when I put the Google Drive form out for these 13 topics, only 12 people applied. And the one topic that nobody wanted to do was hematology. And that is the sole reason why I'm standing in front of you today. So let's get straight to it. Hematology is a topic that is taught in quite a bit of detail in second year. You need to know a decent amount and it'll carry on throughout third and fourth year, but there's only certain parts of it that are directly clinically relevant. As you can see, this was the Med 2042 exam that I sat last year. I understand that your exams are a bit different in terms of their setup this year, but I'll just go over the mark breakdown that we had. So as you can see, out of 98 marks, hematology was 7, which is surprisingly, actually a little bit, but the main bulk of your marks are phys, pharm, and anatomy. So I would definitely recommend those being the main ones that you focus on. And as you can see for hematology, the median was 6, and it was definitely the topic that everyone sucked at. So the fact that everyone got a median of 6 means essentially that the questions that they ask during the exam tend to be quite clinically relevant and not too specific and not too difficult. So my lecture is going to focus on all the big important ideas that you guys will need to know for the exams and for the next couple of years. This is a breakdown of our VIA last year. I don't know if I'm meant to show you guys this stuff, but hematology, as you can see, was making up 2 marks of a VIA. So like, and the cohort median was 2, so don't even bother studying. Heme in second year and even in Year 3B is pretty buzzwordy. So I'll try and teach you a lot of the important buzzwords because let's be honest, that's all you fucking care about. But I'll teach you some of the non-buzzwordy stuff too because it'll be useful in terms of your clinical practice and placements next year, as well as fourth year and onwards. So maybe it'll help you get a bit of a broader idea of the topic as a whole. So we'll start off with some of the basic topics of hematology. Couple of things to note before we begin. Number one is that you probably don't have to take notes, so feel free to close your laptop. I'll upload the slides a bit later when I have a chance. And secondly, if you have any questions, like just yell out. Let's keep this pretty informal because I've already made it pretty informal. So we'll begin. Hematopoiesis is obviously the creation of blood cells of any kind of type. And there are 2 types of hematopoiesis, intramedullary and extramedullary. Where does intramedullary occur? Someone yell it out. Yeah, good. So medullary means bones, intra means within the bones. Where does extramedullary usually occur? Don't say outside the bones. Come on, someone yell out. Spleen, good. So spleen plus like, I guess, a few other places. So intramedullary hematopoiesis occurs in mostly your big bones. So your pelvis, your vertebrae, as well as the sternum for some reason. Extramedullary tends to occur in your liver, as well as your thymus and spleen. Those are the 3 main locations that you just need to be aware of. So this occurs to a great extent during fetal development. After birth, the most common locations would definitely be bone marrow plus thymus. And remember, when we're talking about hematopoiesis, we're talking both about your red blood cells, but also your lymphocytes, etc. So we'll go into a bit more detail about that stuff later on. This is probably your holy grail. Don't memorize it, but just try and get a good understanding of this diagram because it will really determine a lot of the blood cancers that you'll have to know, as well as just the general development of cells. So the main things that I want to highlight are, can we get this one? So the main things that I want to highlight are the two main lineages. So as you can see, you've got myeloid. Oh, that doesn't work. Okay, I'm not going to play with that. That's okay. So the two main lineages that you have, if you can see the mouse, are myeloid as well as lymphoid. And the important things for you guys to be able to differentiate are between these two main lineages, because these essentially determine any kind of blood cancer that you guys will need to know in second year. So when it comes to lymphoid, the main three types of cells that you need to be aware of are your T, B cells, as well as your natural killer cells. So those three encompass all of your lymphoid ones. And obviously your B lymphocytes can differentiate further into your plasma cells, which will make antibodies, et cetera, et cetera. Myeloid, on the other hand, encompasses literally everything else. The important ones to note are that you have your platelets and thrombocytes occurring from your myeloid lineage. You have your red blood cells from your myeloid lineage. You have myeloblasts. I'm sure during your heme lectures and stuff, people would just like blasts, blasts, blasts. This is what they were talking about. And then you've got your other kind of secondary immune cells. So your macrophages, eosinophils, neutrophils, and basophils. So this is the basic outline of how blood is formed in your body. And I'll refer back to this a couple of times as need be. So I'm a bit off the cuff. I don't remember what these slides are on. So RBCs, so red blood cells. We'll go over some of the important, I guess, key points, but I won't go into too much detail because honestly, this probably isn't going to be examined. But what is the formation of red blood cells kind of regulated by? EPO, good. Which is made in the kidneys. Yeah, nice. All right. You guys already know this stuff. So red blood cells' direct precursor is what type of cell? Reticulocytes, easy. And where are they made? Bone marrow, good. And after 2 or 3 days of maturation and release, these reticulocytes will become your erythrocytes. So the reason that I focus on this is that reticulocytes are a reasonably important cell type that I'll touch on a bit later, but not in too much detail once again. Red blood cells, so how many subunits make up a hemoglobin molecule? Cool, and how many O2 can bind to each hemoglobin? Good. And then there's a few different types of hemoglobin that you need to be aware of. So the main types of hemoglobin that you will see in regular blood cells are HbA, and then you've got HbF hemoglobin, which is your fetal hemoglobin, as well as HbA2, which is kind of like a shitty hemoglobin that doesn't appear too much. It's in a very small percentage in your blood, but these become important when it comes to discussing some other clotting and blood disorders that I'll talk about a bit later. But that's why I just wanted to cover this stuff as like a baseline level of knowledge. Next thing that I want to go over is some of the types of cells. So it's unlikely you'll be given any histology slides. For your sake, I hope you won't be given any histology slides. But you do need to just have a very general understanding of the different kind of cells that you can encounter and what they look like. So just as a very general breakdown, neutrophils are classically a hypersegmented nucleus. So they'll have 3 to 5 different lobules. Eosinophils have a bilobulated nucleus. Basophils have, yes, Denali? What did everyone say? Oh, are they not here or are they? Oh, okay, okay. So when it comes to hemoglobin, there's one main oxygen molecule binding per hemoglobin. And then eosinophils are bilobular, basophils are deep blue, have a deep blue staining. Monocytes have a C-shaped nucleus, and lymphocytes have a large round nucleus with a thin cytoplasm. Wait, can I see the questions coming up or is that not possible? Okay, there. Yeah. Okay, I don't want to look at the chat. No, that's okay. Yeah. All right. And then where were we? Lymphocytes. The main thing to note about lymphocytes is that they have a large nucleus with a little bit of cytoplasm, not much. So as you can see, there's a large area of purple nucleus. And then finally, you've got your plasma cells, which have lots of rough like RER. And you can see this if you take a look closely. You can see some kind of like granular formations in those cells, and that indicates your rough endoplasmic reticulum. So that's all the basics. You guys probably know all of that. So we're going to move on to some more clinically relevant details. This stuff is important not only for your exams, but later on. So let's talk firstly about anemia. These are just some of the important normal values that I recommend you try and memorize. So your hemoglobin should be over 130 for men and over 115 for women. Your mean corpuscular volume should be between 80 and 100. So your most important results on a blood test will be HB as well as MCV, at least at a second year level, because these will determine what type of anemia you're dealing with. So those are the two important ones. There are obviously others such as like hematocrit, etc., but those are less important, especially in second year. So some of the symptoms of anemia, just in case you guys get any clinically relevant questions, these are reasonably important to know, and they do come up in your hem OSCEs. You cover most of them as well during your exam, but I'll just go over some of the weird ones. So pallor and pallor are really straightforward. Tachycardia, why might you get tachycardia? Can one person, yeah, okay, circulation, that makes sense to me, cool. Dyspnea and fatigue, quite straightforward as well. Pre-syncope and syncope, decreased oxygenation, especially to the brain. Angina and palpitations are a bit of a maybe. You can actually get what's called a flow murmur if you have anemia. So if you see any clinical questions that have a murmur, don't completely rule out anemia. Koilonychia is a nail sign. Pica is when people want to eat like rocks and ice and shit. And then angular stomatitis and glossitis are usually your mouth signs. So angular stomatitis is when you see creasing on the sides of people's mouths, and glossitis is inflammation or kind of enlargement of the tongue. And finally, pruritus is a bit more specific. What kind of anemia might you see pruritus in? Did someone say hemolytic? Okay, someone said hemolytic, so we'll go with that. We'll go into more detail about those signs a bit later on. But let us begin with microcytic anemia. What are the main causes of microcytic anemia? Iron deficiency, thalassemia, chronic disease. Wait, what? Lead poisoning, good, one more. Sideroblastic, awesome. So the acronym is TAILS for remembering microcytic anemia. Know this, commit it to memory, it's actually important. You'll need to be able to determine the types of anemia based on number one, the histology, which will tell you if it's microcytic. Chances are it's hypochromic. And then you'll need to determine what like subset of microcytic anemia it is based on other signs, past medical history, etc. So let's firstly talk about thalassemia. Two types of thalassemia, alpha and beta. Most of this is very buzzwordy. If you see these words in like the question, you can be pretty certain about the type of anemia. So alpha thalassemia, about the type of thalassemia. Alpha thalassemia classically occurs in Asians and Africans, A and A alpha. And it's essentially a defect of the alpha chain of your hemoglobin molecules. And what this does is it leads to an excess of your beta chains in kind of a compensatory mechanism. So in order to diagnose this, you need to do DNA PCR to work out like the genetic defect occurring here. Beta thalassemia is like your buzzword. If you see Greek or Mediterranean, you can be pretty sure it's beta thalassemia. They don't throw around Mediterraneans and Greeks unless it's thalassemia. These are usually defects of the beta chain in hemoglobin, which makes sense given its name is beta thalassemia. And in this case, you'll usually be given a blood test that details some of the other types of hemoglobin that can be seen. So the main ones that you'll see are delta chains. So if you see delta chains, start querying whether this is beta thalassemia or not, as well as HbA2. So what you need to do in this case is you want to take a sample plus use electrophoresis to diagnose. As you can see, there are a couple of types of cells that are common to thalassemia. On one side over here, these are teardrop cells. Makes sense because they look like a teardrop. And secondly, over here is what we'd usually call target cells. Once again, they look like a target. And these are usually seen in thalassemia patients. Secondly, you can see a hair on end picture on x-rays. Less likely that they'll give you this kind of x-ray because it's kind of niche. But just in case they do remember that this is thalassemia. So literally everything on this slide is by association thalassemia. It's all buzzwords and pictures. Moving on to iron deficiency anemia, because this is probably a reasonably important one. If you see vegan, they're probably iron deficient. Good to go. All right, let's continue. Let's go on with iron deficiency anemia. So as I said, if you see vegan, they're probably iron deficient. Another few things to consider are GI bleeds. These become really important, especially when you get to hospital. If a patient is bleeding internally via something like a bowel cancer or something such as like a Mallory-Weiss tear, a peptic ulcer, chances are they're going to get iron deficiency anemia because they're losing a certain amount of blood. This is classic of GI bleeds. So keep an eye out. If you see peptic ulcers or bowel cancer, always consider iron deficiency anemia. Secondly, malabsorption. This can occur for a variety of reasons. I don't know, like a gastrectomy, etc., can cause iron deficiency anemia. And then you've also got things such as menorrhagia, which is very classic for iron deficiency anemia. And finally, pregnancy due to increased requirements for nutrients and iron. The specific symptoms of iron deficiency anemia are pica and koilonychia. So these are very specific to iron deficiency anemia. You don't really see them in other types. And your management is literally to give these people iron. If it's non-severe, give them per oral, or if it is severe, give them IV. In terms of investigations, you'd want to do iron studies. Just memorize these very basic iron study results. So if you're iron deficient, you'll pretty much get everything low, except for your TIBC, which will be high. And finally, on your blood films, you'll see literally like a ton of different cell types. If it looks weird, it's probably iron deficiency anemia. You've got anisocytes plus poikilocytes, which are varying kind of sizes and shapes of your red blood cells. You've got pencil-shaped cells as well as hypochromatosis, which makes sense. Your cells are going to be hypochromic given the lack of iron and thus decreased kind of red color to the cells. Moving on, macrocytic anemia. The other types of microcytic anemia are rare or not important, so I'm not going to go into them. Like who the fuck's getting lead deficiency or, sorry, lead poisoning these days? Macrocytic anemia, lead deficiency, sorry, my bad. What are the causes of macrocytic anemia? B12, folate, what else? Alcohol, good. Anything else? Pregnancy, yep. Thyroid, yeah, good. So the main ones that you need to know are alcohol, B12, folate, as well as endocrine deficiencies. Cytotoxic drugs such as methotrexate chances are you're not going to be tested on that. And then dysplasia, once again, chances are you won't need to worry about that. But these are the main types of macrocytic anemia you need to be familiar with. So if there are 3 that you remember, make it alcohol, B12, as well as folate. So B12 and folate deficiency are pretty straightforward. If you're deficient, you have macrocytic anemia. B12 is absorbed in the terminal ileum. Important thing to note, hopefully you learned that during GI. This kind of deficiency is classic in patients who have Crohn's disease, who are once again vegan, who have like pernicious anemia, what's pernicious anemia? Good, intrinsic factor, whoever said that, well done. So B12 deficiency can also cause irreversible peripheral neuropathy. So you want to be very aware of people who have some kind of malnutrition, because if you get peripheral neuropathy because of B12, you can't really go back from there. Folate, on the other hand, is absorbed in the jejunum. And then once again, if you have Crohn's disease, it's not ideal in terms of your hematological kind of conditions. But the other things to consider in terms of folate are pregnancy and methotrexate. Next is normocytic anemia. Can anyone just rattle up a couple different causes of normocytic anemia? Good, hemolysis. Aplastic, good. GI bleeding. Yeah, so GI bleeding starts off normocytic and then becomes microcytic, but good otherwise. I'll just go over the 2 different main categories. So normocytic anemia is very much so dependent on the presence or absence of reticulocytes. If you have a high reticulocyte count, this means your bone marrow is trying to replace non-existent blood cells. So in these cases, it's usually some kind of hemolytic cause. So stuff like G6PD, hereditary spherocytosis, autoimmune, as well as sickle cell are classic causes of high reticulocyte count. Low reticulocyte count means whatever is producing your blood isn't doing a good enough job to even produce reticulocytes. And this is classic in some kinds of marrow failure. Renal failure, why might renal failure cause it? Good, EPO. Chronic disease, aplastic anemia, and then some kinds of cancers and fibrosis can also cause a low reticulocyte count acronym. So while there is, there's no technical acronym, I would recommend, if you're struggling and if you're lazy, memorize this, because this is just a basic overview of some of the important types. So acute bleeding initially can cause normocytic, bone marrow failure, aplastic, anemia of chronic disease is also important, destruction internally in terms of hemolysis, and finally EPO deficiency. So I'm going to just rattle out some of these. Please tell me if they are high or low reticulocytes. So if you have acute bleeding, what do you think it is? Okay. Bone marrow failure, if good. Chronic disease. Okay. Destruction high, good. And then finally, EPO deficiency. Well done. So chronic disease, you'd be considering low reticulocytes. Moving on. Aplastic anemia. So aplastic anemia, very simply as a definition, your bone marrow isn't working properly. And as you might expect, this causes pancytopenia. What does pancytopenia mean? Everything is low. Good. So because your bone marrow produces pretty much everything, all of your cell types are low. So it's very logical. And thus you have low reticulocytes. There's a few different causes of aplastic anemia. I put them up there. They aren't too important to know. And the way that you'd want to diagnose this is to do a BMAT, so a bone marrow aspirate and treat fine. And this will tell you kind of the etiology, and it will confirm your diagnosis of aplastic anemia. Moving on to hemolytic anemia. So this is a bit more important. There's a few different causes. Hemolytic anemia, quite straightforward, is the premature destruction of red blood cells from a variety of different causes, which we'll be going into. There's some notable findings. So hemolytic anemia tends to have a hepatobiliary picture. You get jaundice and pruritus because it's a pre-hepatic cause of jaundice. Make sense? Did you guys learn this? Excellent, good. You'd also have a few other signs such as increased LDH. Because it is kind of related to your liver, you'd have increased bilirubin, which will give you pruritus and scratching. And you'd also have a decreased haptoglobin. So what does haptoglobin do? Or like, how does it play into all of this? Sorry? Kind of. So haptoglobin, the way that's easy to think about it is it will essentially replace blood cells as they are hemolytically destroyed. So essentially, I think it was meant to say an increased haptoglobin. Sorry about that. So the few different causes that you need to be aware of are G6PD deficiency. You don't really need to know anything about how this works, but if you see fava beans, it's G6PD deficiency. Autoimmune hemolytic anemia. So in autoimmune anemia, you do a Coombs test. Could be direct, indirect. Classically, they'll give you a positive direct Coombs test, and this will confirm your diagnosis of autoimmune hemolytic anemia. A few other things you might see are spherocytes on your film, and then chances are you don't need to know the difference between warm and cold hemolytic anemia because it's quite niche, and the chances of them putting it within your 7 marks of heme are quite low. But just in case, warm and cold tend to be above or below 37 degrees, causing this kind of hemolysis. Finally, you have sickle cell anemia, which is autosomal recessive, classically in African populations because it's protective for malaria. And then on your blood films, you'll see sickle cells plus Howell-Jolly bodies. So if you take a look here, these are sickle cells. They're called sickle cells because they apparently look like sickles. Howell-Jolly bodies are these little dots that you see within the blood cell. A couple other things to point out. So in autoimmune hemolytic anemia, you see spherocytes. They're called spherocytes because they look spherical. So as you can see, they're very round. And finally, in G6PD deficiency, bite cells, as the name suggests, it looks like someone's taken a bite out of a cell. And then you see Heinz bodies, which are a bit niche. They're once again blue dots, but they're usually present on the outside or along the membrane of the cell. Those are kind of the classic buzzwords and histological signs that you need to be aware of. Moving on, different types of hematological cancers. This is honestly quite low yield, even though they try and teach it to you, and they don't teach it to you too well. But I'll go into detail about a couple just in terms of the buzzwords in case they do come up. Referring back to this diagram, there's a few things that I want to point out. This is a really good kind of basis for you to understand where your cancers will occur in hematopoiesis. So bless you. There are different places at which the cancer can arise. And essentially, this diagram will help you determine where the cancers come from. So we'll start off by looking at some different types of leukemias. There are 4 main types. Here's a few general rules if you don't want to memorize your buzzwords. So lymphoid leukemias will obviously have a large amount of lymphocytes. So if you see any kind of blood results with higher lymphocytes, think lymphoid leukemia. Myeloid leukemias will classically present with lots of neutrophils. In terms of acute versus chronic, acute leukemias are obviously more acute, and they'll usually present with blasts, which are immature cells. And if you go back, blasts are over here. So myeloblasts, very classically, AML, myeloid, and this is classically in acute leukemias. Secondly, you have chronic leukemias, which tend to be more so mature cells. So these are sites. This is a very general outline that might help you work things out in your head, but I would recommend trying to learn some important buzzwords for these. So I'll just be going over these in a low level of detail, so that this will be mostly like exam relevant things to look out for in terms of pattern recognition. So ALL is acute lymphoblastic leukemia. So it is a very aggressive blood cancer that you should be aware of that classically presents in young people. So children usually will get, in terms of if they do get a blood cancer, it will be ALL. The things that you need to look out for are the presence of lymphoblasts as well as hepatosplenomegaly. Buzzword is Philadelphia chromosome, which is your translocation T922. You don't even have to know what that means. It's just an important buzzword. And then there is a low level association with Down syndrome, but this classically won't come up in your questions. It'll mostly be the other clinical findings. CLL, on the other hand, is a proliferation of mature, small lymphocytes. And these are most classically in adults. The way I like to think of it is ALL is pretty much the one that's specific for children. All the others are adults or old people. Chronic lymphocytic leukemia, the main buzzword to look out for is smudge cells. As you can see, it's like a cell that's been smudged. So that would be the main buzzword to look out for in CLL. However, the chances of it coming up are once again a bit low. Moving on, AML, acute myeloid leukemia. So acute myeloid leukemia is also very aggressive, but it's mostly present in older patients. The classical signs are gum hypertrophy plus your cancer B symptoms. Do you guys know what B symptoms are? Is that a no? Okay, so B symptoms are your systematic symptoms associated with blood cancers and hematological malignancies. This stuff is your night sweats, weight loss, lumps and bumps, etc. They're kind of just grouped into B symptoms, and you can pretty much see them in almost all types of leukemia. The last thing in terms of buzzwords is that you'll see myeloblasts plus Auer's rods. So Auer's rods are these tiny lines that you can see within cells on that have like your blasts from acute myeloid leukemia. So that's one thing to look out for. Finally, type 4 is chronic myelogenous leukemia. Once again, it's also in adults, also chromosome T, translocation 922. And then another buzzword is your BCR-ABL fusion protein. So these two classically, if they're put together, 922 BCR-ABL, it's going to be CML. So you want to treat it with a tyrosine kinase inhibitor. It is important to know tyrosine kinase because it is somewhat specific to CML, but that's all the detail you need to know. These two slides sum up AML, ALL, CLL, AML, and CML in a very basic amount of detail. But honestly, you don't need to know too much more for your exams because if these buzzwords come up, you can be quite certain that these are the diseases you're dealing with. Moving on to lymphoma. So lymphoma is more so focusing on your lymphoid progenitor cells. And we'll be taking a look at a couple different types of lymphoma. The two main types you might have learned so far are Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is very buzzwordy, very easy to pick out. You just need to know Owl cells or Reed-Sternberg cells, plus a past medical history of EBV or glandular. And very classically, these patients get tender lymph nodes whenever they consume alcohol. Those are the three main buzzwords for Hodgkin's lymphoma. It's quite rare, but I've seen one practice OSCE from second year that was a heme history, specifically about Hodgkin's lymphoma. Chances are you won't get something that difficult because it's second year and they don't want to scare you too much. But if you do see anything related to like lymph nodes, cancer B symptoms, as well as Reed-Sternberg cells on some kind of histology, then it is important to keep that in mind. Non-Hodgkin's lymphoma doesn't really have any buzzwords. Like they don't have Reed-Sternberg cells. So it's very unlikely for it to come up, but there are a few buzzwords for more specific types that you might need to know. So if you have non-Hodgkin's lymphoma, there's a classic presentation where this person already has HIV. A few different types of lymphoma are Burkitt's, follicular, and mantle cell. Just remember these buzzwords here, 8, 14, 14, 18, and then finally 11, 14. That's probably all you need to know. In terms of other symptoms, cancer B symptoms, going to be lymphoma, and then just work out what type based on the buzzwords you see here. The last one we'll look at in terms of the omas is multiple myeloma. Multiple myeloma is the clonal expansion of plasma cells, and these are classically monoclonal, so they're producing one type of antibody. Your symptoms can be seen here. This acronym is CRAB, so hypercalcemia, that's the C, Raynaud's anemia, and bony lesions. So these people usually present firstly with some kind of lower back pain. You'll see rouleau bodies on film, which are basically strings of your red blood cells. And then on urinalysis, you might also see Bence-Jones proteins. Once again, these are all buzzwords. The important basic things that I want you to remember is that multiple myeloma is specifically about plasma cells. So if you have a malignancy of plasma cells, it's going to be a myeloma. Whereas if you have a leukemia, it's going to be either myeloid or lymphoid, depending on the type. And finally, obviously, there's your lymphoma, which is more so lymphocytes. And the main ones to know are Hodgkin's and non-Hodgkin's. It's a very general overview. Don't bother going into too much more detail because we have way more important things to study. Finally, we'll go into myeloproliferative disorders. If you see JAK2, it's one of these, like guaranteed. So just keep in mind that JAK2 is a buzzword. There's a few different types that I'll go over very quickly. There's ET, essential thrombocytosis. When you see thrombocytosis, thrombo means platelets, cytosis means lots of them. So you have a clonal expansion of platelets, which paradoxically results in poor clotting. So what happens is that these guys have a history of spontaneous dysfunctional clotting, as well as stuff like bleeding, stroke, DVT, PE, etc., as well as visual disturbances, which is classically something like a TIA, which I'm hoping you guys have covered. Transient ischemic attack, cool. Next, we have primary myelofibrosis. This is once again a clonal proliferation. However, it's of your hematopoietic stem cells. What happens is within your bone marrow, you've obviously got a lot of different types of cells, and you have a proliferation of specifically your hematopoietic stem cells. This essentially takes up a lot of space and causes the remaining area of your bone marrow to fibrose, which is why it's called primary myelofibrosis. The one thing to remember is that you can have teardrop red blood films, and you can also have massive hepatosplenomegaly. But aside from that, it's quite a rare condition. Chances are, once again, you won't be seeing it. Finally, we'll look at polycythemia rubra vera because we've already done CML. PRV is your very classic buzzwords, pruritus in the hot, like after coming out of a hot shower. So people are very itchy after coming out. Polycythemia rubra vera is the clonal expansion of red blood cells specifically, which causes increased viscosity in your blood and a high hematocrit, which thus increases your chances of thrombosis. So PRV is also, it can come up, and it's reasonably important for you guys to remember the classic presentation, which is pruritus after a hot shower. Moving on to hemostasis. Is this too fast or is this a good pace? Good pace? Cool. Hemostasis. There's two types of coagulation that you guys need to be aware of. Primary as well as secondary. Primary is pretty straightforward. It's your platelets that clot. And it's potentiated by two main factors, your thromboxane as well as ADP. That's a very brief breakdown of primary coagulation. The importance of thromboxane and ADP is that they relate back to your antiplatelet drugs. Next, you have secondary coagulation, which is your coagulation cascade. It's initiated when you have a breach in your endothelium, which exposes tissue factor, so TF. Hemostasis ensues, and what happens is you eventually produce small amounts of what's called thrombin. Thrombin eventually converts thrombinogen, I think it was meant to be fibrinogen to fibrin. And finally, thrombin will generate and produce proteins C and S. And this is kind of important because they produce a negative feedback loop, which will decrease the clotting over time, because you don't want too much clotting ever. Just in a very brief overview, I'll go over extrinsic and intrinsic. I'm not too sure if you guys have been taught how to kind of memorize and learn intrinsic and extrinsic pathways, but the way that I like to do it is, so intrinsic obviously has a lot of steps that can be kind of confusing. The two things to remember are that you always go from the original factor to factor A. And then the way to remember the actual numbers is that you start with 12, which ends in an E. E, you next have 11, which ends in an N. After that, you have 9, which ends in an E. It worked up until then. Sorry? Yeah, next one's 8. So technically, like, in this diagram, it's kind of not well shown, but technically your next factor is going to be 8, which is why you go from 9 and ends in an E, you go to 8, and an 8 ends in a T, then you go to factor 10. Have you guys been taught that? You're welcome. So 12, 11, 9, 8, 10. Simple. And 10 is kind of your joining point where your extrinsic meets your intrinsic. Extrinsic, the only thing you need to remember is that it goes from tissue factor straight to factor 7. That's all there is. It's not too much, so you can memorize it. After factor 10, you essentially have the same pathway between all of these. You have prothrombin to thrombin, which, as I was meant to say before, converts fibrinogen to fibrin. Sorry about the typo. That is a very basic overview of intrinsic and extrinsic. Try and remember that, like mnemonic kind of or memory technique kind of thing, just because it helps you differentiate which factor goes where. We'll move on to coag studies. So this is probably the most important application of your knowledge. There's 2 types of coagulation studies. PT, prothrombin time, also known as INR, which specifically measures your extrinsic pathway. Now, there's a few things that can cause prolonged PT. The main ones are warfarin, liver disease, vitamin K, factor 7 deficiency, as well as DIC, disseminated intravascular coagulation. Don't worry about that. Why might liver disease cause prolonged PT? I'm hoping someone said that your factors are produced in your liver. All of them except von Willebrand's is produced in the liver. So any kind of liver disease is going to screw up both of these to a certain extent. Secondly, warfarin, as explained. So warfarin is a vitamin K inhibitor. We'll go into more detail about it later, but what kind of factors are mostly influenced by vitamin K? Good, so the TV channels, 2, 7, 9, 10. That's the easiest way to remember it. Next, you have your prolonged APTT, which is specific for your intrinsic pathway. So your intrinsic pathway is your longer one. It's your 12, 11, 9, et cetera, et cetera. It's essentially everything except factor 7. And once again, the causes are liver disease, specifically heparin in this case as well, hemophilia, von Willebrand's disease, and then DIC. Now, the one thing to note is that vitamin K is more specific for extrinsic disease. The reason is vitamin K firstly acts on factor 7. And factor 7 is part of your extrinsic pathway. The others, so 2, 9, and 10, will be affected later on. Thus, you'll have a prolonged APTT later on if you have if you're taking warfarin or you have a vitamin K deficiency. Finally, if you have both of these prolonged, you can have combined factor deficiencies, deficiency in everything, or severe vitamin K deficiency, which, as I said, will inhibit 2, 7, 9, and 10. Moving on. Bleeding disorders, the ones you need to know are hemophilia and von Willebrand's disease. Chances are you already know these, but the most important things to know are that these are X-linked recessive, so they are to a certain degree congenital. What factor is influenced by hemophilia A? 8, good. Hemophilia B? 9, good. And C? C is rare, like it's a buzzword. So hemophilia A is factor 8 deficiency, which is the most common type of hemophilia. 9 is specific to hemophilia B, it's more rare. And then super rare is your factor 11 deficiency. If you see the buzzword Ashkenazi Jews, chances are it's going to be hemophilia C. These are the kind of symptoms you get. A lot of them are bleeding and bruising related. And finally, the thing you want to do is coagulation studies. What you'll see increased is your APTT, because 8 and 9 are both in your intrinsic pathway. Von Willebrand's disease is the most common clotting disorder, more so than hemophilia. Symptoms are the same. That's pretty much everything I'm going to go over, because that's probably all you'll need to know for clinically related questions. Let's move on to hypercoagulability. Can someone tell me the 3 things in Virchow's triad? All right, better. Can one person yell them out? Stasis, good. Sorry? Hypercoagulability. Endothelial damage. Good job, guys. So the three main factors in Virchow's, whatever, triad are endothelial injury, some kind of altered blood flow, so usually stasis, and finally a hypercoagulable state. So what are some examples of endothelial injury? So trauma to a blood vessel, and then atherosclerosis counts as endothelial injury. So that's why if you have high levels of IHD or atherosclerosis, you are predisposed to AMIs, DVTs, strokes, etc. Altered blood flow. Why might you have a state of altered blood flow? Sorry? AFib, yep, that's one example. Anything else? So the classics are planes and surgery. If you get off a plane, you are immobilized during your flight, you're hypercoagulable, you're in a stasis kind of state. And then secondly, long surgeries and procedures, once again, stasis. And finally, hypercoagulable. What are some things that can put you in a hypercoagulable state? Chemo, usually, probably you won't see that in like an exam. Estrogen, so combined oral contraceptive pill, really important. These are the most common ones that you need to know. So trauma, atherosclerosis, flight immobility, and polycythemia rubra vera can cause altered blood flow. And finally, COCPs, cancer, smoking, and pregnancy. The most common clinical scenario where you'll get tested on Virchow's triad are DVTs and PEs. You can see pretty much everything here. The classic presentation is sudden onset pleuritic chest pain, post-surgery or flight, pink frothy sputum, and you might get a unilateral leg pain and swelling. Important because it's unilateral. You don't get DVTs in both legs, otherwise you're really unlucky. And then the main investigations you want to do, number one, gold standard CTPA, just remember that. VQ scan might come up in questions. D-dimer, like they teach you that in second year, but no one does it. D-dimers are pretty non-specific, so I'd recommend keeping that as like a backup. All right, cool. Blood types. That's it. I'm not going to go over it because hopefully you guys understand it. A, B, and O are the main ones you need to be aware of. Do you guys understand it? Cool, I won't waste your time. Rhesus is somewhat important because it'll tell you it's your positive. When someone's like A positive in terms of their blood, because they are rhesus positive. This is only important in cases of pregnancy because you can have hemolytic disease of a newborn. What happens is your first birth, your mother is exposed to Rh blood if they have a rhesus positive baby. And thus, when they have their second birth, they've created an autoimmune response to rhesus positive antigens, which means they pretty much try to internally like autoimmune destroy the baby. The management is essentially after the first birth to give anti-D and destroy all your rhesus positive cells that may have been transferred from the placenta to the mother after the first birth. So this management is all determined based on like blood tests done before. Pharmacology. Oh, we're almost at the end. Cool. So the main antiplatelet therapies that you need to know are aspirin and clopidogrel. Just remember, aspirin is your COX-1 inhibition non-specific that affects thromboxane A2. Clopidogrel inhibits your ADP receptors. That's all you need to know. Just remember that dual antiplatelet therapy is when you give both of these at the same time. Thrombolytics are, the main one you need to know is alteplase, which is a tissue plasminogen activator. It is a clot buster. You'll give this to someone if they have something such as a PE, pulmonary embolism. Anticoagulation. So a couple of these are actually important, mostly warfarin, heparin, and low molecular weight heparin. Warfarin is important because you need to be aware of how it kind of works. So as I said before, it's a vitamin K antagonist that affects 2, 7, 9, and 10. And 7 is affected first because it has the shortest half-life. You need to do constant INR monitoring in order to like monitor these guys' INR levels, and you want to keep it at a range of 2 to 3 if they're normal. But if they have some kind of valvuloplasty, so valve replacement surgery, you want to keep it between 2.3 and 3.5. That was actually taught to us. It's kind of important. A few other things to note are there are some contraindications, specifically if they're pregnant, don't give it to them. You need to give them heparin at the start because warfarin takes some time to come into effect. So you'll need to give these patients heparin initially and then wean them off it. Vitamin K can be given as an antidote if they have too much warfarin. And then finally, you need to be careful of them taking antibiotics as well as their diet. Because if you change the level of vitamin K in their body, i.e. green leafy vegetables, this will impact the warfarin's effect on their coagulability state. Next, you have unfractionated heparin. Just remember it's used as an IV infusion, and you need to do APTT monitoring. And finally, low molecular weight heparin is subcut, and it's used for long-term prophylaxis, and it's selective for factor 10. Everything is summarized on this slide. Finally, you have DOACs, which are new, and they tend to be used as a replacement for warfarin a lot these days. The two kind of methods of actions are that they can be factor 10A inhibitors or factor 2A inhibitors. So this means that they work on both of your pathways. The main names to be familiar with are rivaroxaban, apixaban, and dabigatran. Those are all your DOACs. Oh, cool. So we'll do some questions. Let's keep this choppy because I want to leave. Man presents to GP, dark pigmented skin and hepatosplenomegaly. Iron studies showed increased ferritin, decreased transferrin, and HbA1c. Actually, I didn't teach you guys this. Does anyone know the answer regardless? Good. If you see dark pigmented skin, it's definitely hemochromatosis. You typically won't see this in an OSCE, and typically not even in an exam because it's quite rare as a disease. But yeah, it's a question that I stole from someone. So next, which of the following would you expect to have a low reticulocyte count? Aplastic anemia. Well done. What is the diagnosis if this is an 18-year-old female? Nice, good try, but take another look. Look at the very last row. Cool. So the stuff in red is the abnormal results. That's even once you go to hospital, and if you see anything red, it's probably abnormal. So your hemoglobin is low for this woman. So it's definitely some kind of anemia. In this case, because of the MCV as well, it's Macrocytic Anemia, and it's going to be hypochromic, which is confirmed by your film. But the important thing here, the one reason it isn't iron deficiency anemia is that on your hemoglobin electrophoresis, you have elevated HbA2. HbA2 essentially replaces hemoglobin in thalassemia cases, and specifically in thalassemia beta, when you have low hemoglobin B levels, then that's going to be replaced by hemoglobin A2. So that is the answer in this case. 30-year-old female presents with 3 months of menorrhagia. She claims to be vegan, blood test. So you know the diagnosis already, but what would you do to treat her? Cool. So in this case, I would say, given all of the details, you'd go for oral rather than parenteral. It's kind of a bit dodgy in that you'd probably need her HB levels in order to differentiate between PO and IV. If it was severe, you'd go for IV. But in this case, since she's presenting to a GP with a 3-month history, claims to be vegan, you're probably just going to go with oral iron. Patient presents with headache and numbness in the limbs. Patient shows elevated HB and HCT, which is your hematocrit, which is the least likely. So, alcohol? Yeah. So in this case, we're asking which is the least likely. So, sorry, the least likely. PRV will get you increased hematocrit. Male athlete who's undergone altitude training, so same stuff as increasing your EPO and blood cells, this will have an increased hematocrit. Lance Armstrong, who's doping on EPO, increased hematocrit. And finally, if you have a long smoking history as well as COPD, in some cases, this can make you somewhat hypercoagulable or increase your HCT. So that's an important thing to know. Cool. So, okay, so that was just a link to the OSCE document. I think I shared it with you guys earlier. Yeah, so this, in the OSCE document, I go through the entirety of the heme exam, just summarized. Hopefully that's been somewhat useful to you guys. But essentially, if you just use that document in order to determine how you do a heme examination, you should be good. In terms of a heme history, once again, the basics to ask are lumps, bumps, cancer B symptoms, as well as, you know, anything along those lines. There's classically not going to give you a heme history because there's not too much for them to ask. But heme exam, it's all in that document that I shared earlier on. Denali can share it again later. That's all. Thank you very much.